I know we don't have much time, Vic, but should we all just put who we are in the chat? Is that the easiest thing, just so that everyone knows?
Sorry, absolutely. Sorry, I'm used to familiar faces, but please put down who you are in the chat, just to introduce yourselves, and then I'll carry on. So I'm just going to share my screen. Hopefully this works. And what really this what this really is about is me first of all giving you all an update of what's happened so far locally with the vaccine, but then also then hopefully giving us a chance to discuss what we do next. Can you see that?
Yes. Yes.
Yeah. So I'm just going to put that on the. Yeah. Is that on the slideshow now?
Yes.
Yeah. Great. Okay. So yeah. Just to start with, then, what actually happened locally. So we spoke a good few months ago now, wasn't it, about when this was all about to start and some of the things we were planning for. And at the time, I said that things were changing so quickly that, from week to week, what was happening was different. And that's exactly how it's panned out. So from where we were in early December to how we actually started delivering the vaccines, a lot has changed. So I'm just sort of going to give you a brief update of what did end up happening. So the Stockwell practices as part of Primary Care Network, as well as the Brixton and Clapham Primary Care Network practices, we came together as one site. So that was 8 GP surgeries that came together that served a population of about 77,000 patients. And the reason that was you remember the first priority groups, the priority group 1, which were the over 80s, and actually the absolute numbers of those were quite small if you looked at per practice level. And the way the vaccines were working, we were getting shipments of Pfizer coming through, which were 1,100 doses per shipment. So to make sure we were using them as effectively as possible, we needed to bring practices together under one site. And so that's basically what happened. We brought the 8 of us together, and the Hetherington practice, which is quite close by, on the border of sort of Brixton Clapham, that was our designated site. And so we launched on the 15th of January for these 8 practices. And as I said, we started with Pfizer vaccines, which need to be used up within 4 days, as soon as they're delivered. And we got through almost 3,500 vaccines within the first 10 days. It was a logistical effort, but it went really, really well, actually, and showed the power of collaboration, actually, with the 8 practices all coming together. And remember, we've never worked together on anything at all, let alone something as big and as complicated as this. So it was a real testament to everyone sort of chipping in and getting on together. So that was the sort of the first 10 days. And then shortly after that, sort of the second or third week in, we had clearance on the AstraZeneca vaccine, the Oxford one. And that the big game changer there was that we were allowed to move it around. So the Pfizer one, as you probably know now through the news, is something that we have to handle very carefully, and we can't transport around too much, whereas the AstraZeneca Oxford one was much more stable. And this allowed us to very quickly then go out to care homes, housebounds, and start doing those. So in the first 10 days, we've done 3,300. By the time we got to day 16, we'd done 4,000 vaccines. And that's because we basically did all our housebounds and extra care home residents and staff as well. And so we'd got to the point quite quickly, within about 3 weeks, actually. So when we got to early February, where we had offered a vaccine pretty much to everyone who was registered at one of our practices. If they were in the priority groups 1 to 4, they would have been contacted and told that they could book in for a vaccine, either at the Hetherington site, or as a housebound patient, or care homes, or indeed, actually, we'd started to even do a few vaccines at practices. So we kept some Oxford vaccines on individual practice sites, because there were some patients who couldn't make it to Hetherington but were comfortable coming to the individual practices. So early February, we sort of offered to all priority groups 1 to 4, and yeah, that's where we'd got to. Please shout out, because the way I'm sharing this, I can't see any faces. So if anyone has any questions, please do ask. Right. I just wanted to make a point about what an amazing effort it was, actually. So it's not just running the site, it's 8 receptionists, 8 reception staff coming together. If you imagine, we all have different booking systems and how we contact patients and things, so we have to uniform all of that. We had clinicians chipping in from all 8 sites, so nurses, doctors, pharmacists, all sort of working on a shared rota. We had an amazing group of volunteers who helped with sort of shepherding patients around the site, but also helping in the backroom staff with capturing admin, because what was really important was capturing the data. It's not just doing the vaccine, but we needed to actually report what we were doing so that NHS England knew how we were doing on the ground and where effort was needed. And during the snow, we had support then to sort of get us through those days as well. We had great support from the Lambeth transport services, who offered their time. So transport, which is for the SEND schools, the special educational need schools. Obviously, schools were down or less utilized, so they had a transport fleet which was available, and they offered it to us. So we were getting patients who were otherwise not mobile enough or didn't have transport to get to the vaccine sites to get vaccinated. So that was great help from them. You've probably seen over the internet and online, we, with the support of the comms team from the LPWP, have been doing social media campaigns with people from this group coming together and creating videos, clinicians, patient journey stories, which have all been really powerful. And actually, we've been a bit of a leader in this. So we've had South East London CCG, who covers 6 boroughs, coming to us, asking us if they can use our videos and brand them. And also I've been contacted by primary care networks from sort of Yorkshire and all over the place, asking if they can have the script to some of our videos so that they can recreate them locally for their patients and GPs there as well. So that was been a great effort as well. And also we've been running some online teaching events. So it's been a really, really great effort all around, I think, and that's really important to highlight. So what's important to sort of say is that there's a lot of confusion around where vaccines are happening at the moment. So I'm trying to keep this as simple as possible. So basically think of it this way in Lambeth. You've got 3 places where you can get vaccinated. You've got hospitals. So for us, that's Tommy's, well, the Guy's site of Guy's and St Thomas's, King's College and St George's. You've also got pharmacies. The last I know, there were 3 pharmacies in Lambeth who were offering it. The plan is for 6 community pharmacies to be able to offer the vaccine. So there'll be 6 pharmacy sites in Lambeth. And then as well as our site in Hetherington, there's 5 other primary care sites across Lambeth as well. So that's Streatham, there's a couple around Streatham, Norwood area, one in Dulwich, Croxford Road, the Oval, which is actually Church Hall, and I can't remember the name of the church hall.
St Mark's.
Yeah, St Mark's, but it's got another name, I think. It's Montgomery Hall, I think, St Mark's. So that's up and running, and that's a huge site where they're hoping to get lots and lots of people through. And then the Kennington site at Hurley. So that's your sites across Lambeth. There's still discussion around another sort of mass vaccination site, which might be a town hall or somewhere else. But these are the ones that I can tell you for definite that are up and running or in the pipeline. And just to sort of clarify, you'll know now, hopefully, that you can actually book yourself through the national booking system for a vaccination if you're within one of the cohorts, the priority cohorts. And if you were to book through the national booking system, you'll go to one of the hospital sites, basically. So you'll be booked in locally to either Guy's, King's or St George's. If your GP contacts you through text and stuff, then that's the ones where you'll be offered appointments at one of the primary care network sites. So either on one, so if we contact you, one of our 8 practices, it will be at the Hetherington. But if you're registered at one of the other practices in Lambeth, you'll then be invited to one of the other 5 PCN sites, which is linked to your practice. So those are really the 2 main ways. And then the pharmacists are kind of supporting primary care and the borough, so they're given lists of patients that have not yet been contacted or vaccinated, and they contact those patients and also obviously offer it to their customers who come by their pharmacies as well. And so yeah, the national booking system, I can share a link on emails if you haven't seen it yet, but it works very similar to the COVID testing website, basically. So you go in there, put in some details, and then it will confirm that you haven't had your first dose yet, and then it will tell you where your local sites are that you can get booked in for a vaccine. If your GP is going to contact you, it will usually be a text first. And the reason we're texting first is because we've got quite a fancy automated service where if you are sort of tech savvy, you can then reply to the text and get or click a link, and then you can book yourself in online directly for an appointment at the Hetherington site. However, as GPs, we know that not everyone can do that, so we make sure that we send out a text to everyone, and then if they've not responded within sort of 48 hours, 72 hours, we will call all those people who have not responded. And after that, if we've not got through to them, say the number's not working or no one's picking up, we will also send a letter to people. So we've got sort of 3 layers of contacting people for vaccines when we contact our patients.
Vic, can I ask a question just about the text message? Is it quite obvious that it's coming from a trusted source? Like, because I know that everyone's getting spammed with text messages with links, and there's a real fear of mine, certainly, and I know a lot of people where you don't want to just click a link. So how do we know it's you guys?
Yeah, that's true, actually. Also, we can tailor our messages. So, for example, our message, so although there's 8 practices working together, each practice sends out its own tailored message. So, for example, from my practice, it will be, dear Grantham patient, practice patient, little thing about please book below, click the link from the doctors, Dr. Sharma, Dr. Wickers, Dr. Ishan. So we try and make it as tailored and as personalized as possible. But it's a good point, actually. I don't know if there's another way we can.
No, I think what you're describing is helpful, like mentioning the names of the those things make it a bit more. I don't know what anyone else thinks, actually, but because the more specific you can make it, that connects it to you and to the patient, I think helps. The challenge comes when it's quite generic.
No, absolutely. Sorry, I'm just checking the screen because I realise I'm also the person admitting people, so I just want to make sure that
I can have a look. Does anyone else want to jump in on that, or just me? No one's saying anything.
Okay. So that's no, but thanks. I'll take that back. If there is a way we can make sure that we are we can make the text more sort of trustworthy, that's a good point. So that's where we are. And the next steps, again, this is all stuff that's out there in the news, but I just want to, I know it's very confusing, so I'm just going to sort of run through it here and hopefully simplify things, not make it more confusing. So we've done priority groups. When I say done, we've offered a vaccine to priority groups 1 to 4, right? So that's everyone over 70 and everyone who was told to shield from last March or April. From this week, we have moved on to priority group 5, which is the 65 to 70-year-olds, and they've been told that they can book just directly via the national booking system. So they're all going to get a letter through the post from government, from NHS England, and details on how to book. And you can just go online. So just like you book for the COVID test, you can do that via the national booking system. We as GPs have been told to concentrate on priority group 6, and that's 16 to 64-year-olds with a chronic disease plus carers. And the reason they've separated it out like that is because we have that data on our system. So we can tell you which ones are the 16 to 64-year-olds with the chronic diseases, who are the carers. So whereas, 65 to 70-year-olds, there's no further information you need. As long as you're in that age, you can book. So that's why they've separated it out like that. They've asked the GPs to concentrate on priority group 6 because we have the data that can identify those people and we can proactively contact them. Whereas they've left the 65 to 70-year-old cohort to self-book or self-refer. Now, in the real world, clearly there's overlap, right? So we're having 67-year-olds call us and we're booking them in if they, because actually they might not know how to use the internet or might not have got that message and stuff. So it's not rigid. So it's not that you can't have your vaccines at your GP site or vice versa. So equally, if you're a 20-year-old who has heard about the national booking system and you are someone who's in priority group 6, there's nothing stopping you from going on and booking on the national booking system. It will book you in. But this is, I suppose, what this is the focus. So we as GPs are being told to focus on priority group 6. But please don't worry, there is overlap allowed, and it's not a hard and fast rule. The the additional stuff that's happened, which is literally in the last day or two, to further sort of complicate things, is you would have heard that there's now additional shielding patients. Now, what's happened there is that obviously we're learning all the time about COVID and who's at risk and who gets complications the most and stuff. And so in parallel, there's been a lot of research being put into sort of retrospective research. So they've been looking at the first wave, the second wave, and who was it actually that was at higher risk of getting the infection and ending up in ITU and dying, and what was the data about these people? You know, where are they from? How old are they? What ethnicity they are? What's their weight? What jobs do they do? What conditions they have? And so, in the background, what's been happening is that they've been putting all this data into sort of algorithms and calculations, and they've come up with a new risk calculation tool called Q-COVID. And this has only been sort of validated and published in sort of scientific papers recently. And from that now, we can take that tool and we can put that into NHS systems. So you can run that tool in GP systems, and it will search people based on their height, weight, ethnicity, postcode, age, plus all their medical conditions, and it will give a much more sort of calculated risk on that person's chances of getting complications of COVID. So not if you're going to get COVID at all, but what's your chances of actually ending up in hospital or ITU? And the cutoff line they've used is anyone who's 10 times at risk of getting these complications compared to the national baseline. And so when you apply that tool to GP systems across the country, what you found was that in addition to the shielded patients that were warned last year, which was a much more sort of, you know, just done by diagnosis, really. It was just, well, these people would be the people at risk. This is much more sort of, as I said, sort of calculations. What they found by running this tool, that there was an additional 1.7 million people that they identified that would be at increased risk. Now, a lot of those are over 70, so actually have already been offered the vaccine and should have had the vaccine. But there's probably about 800,000 people nationally that haven't had the vaccine and would not have been prioritized for a vaccine if we didn't run this calculation tool. So because of that, that's why they've announced this. So we've been told now in GP land that as well as our priority group 6, we need to make sure that we're also looking out for these additional patients that have been flagged through this calculation tool. And so we'll be calling those patients as well to have their vaccine. And all those patients will be notified by letter this week from NHS England, just like the original shielding patients got notified last year. These patients will get notified, and just like shielding patients from last year, they will then qualify for all the support that is needed if you're shielding. So statutory support, delivery of food and shopping, all of those sort of things will be available to these additional shielding patients as well. And that will run at least till the 31st of March. So at the moment, all shielded patients are told that need to carry on shielding to the 31st of March until we get further guidance from the government. So the message really is people don't have to do anything. The public or patients don't have to do anything new. You'll find out by letter that whether you're on this list. That will come from NHS England. Your GP systems will automatically update, so I don't even have to do anything. It's just going to all happen centrally. They're just going. My system's going to suddenly just start showing a flag on certain patients that wasn't there before, and I can search on that, and then I can create a new list of people who need vaccinating and things. So let's just admit big kid are joining. So yeah. So does anyone have any questions on that? Because I know that's quite recent and might be causing some confusion.
I won't bore everyone, but my sister is one of those people, and she had no idea why. So she got called. She lives in Balham, and the GP, when she called her, told her that she needed to book in. She's like, why? And they obviously didn't explain anything that you've just explained here. Yeah. So I've just messaged her now to say, now I know why you've got it. But she was just like she was like, why me? Why? I'm fine. I don't have any issues. I don't have anything. So it's just, again, the messaging, isn't it? That that explains why you're getting it, because it's got her really concerned that it's something they know about her that she doesn't know.
Yeah, absolutely. And the other problem is, I mean, in many ways, we're world leading in the NHS in that we've got one system across all health, like all GPs, so we can run these sort of tools very quickly across the national population. But there are still flaws, and one of them is your tools are only as good as your coding, right? And so there will be discrepancies. So even we are having discussions with some patients where we can't explain why they've been flagged, and sometimes it's an error in the coding. So if there is anyone who's wondering why they're on it, just double check. So for example, BMI, you know, if someone if at some point, you know, 2 years ago when you were checked in with a nurse and had your weight done and the weight was entered wrong, and then your BMI is being calculated wrong by the system, that will then flag you into this system, right? So if there are any queries, then please do double check. But yeah, this is more than just medical conditions. This is broader actually, and looking at much more of the socioeconomic demographic that before hadn't been looked at when we were creating those shielding lists. Okay, shall I move on? Yeah. Okay.
Had a quick question.
Yeah.
So I've actually just gone through the calculator.
Yeah.
And I've noticed that it weighs BMI quite heavily.
Yeah.
And I wonder how accurate this really is, just because BMI doesn't account for body fat. So I could be 80 kg but really hench. But then because it doesn't take into account that I'm quite lean as well, I'm suddenly eligible for a vaccine.
You
know?
Yeah, no, great question. And and that's what I mean by the flaws in the coding. So there will be discrepancies like this, and so it's probably we haven't got much better ways. We know for definite that obesity is one of the big risk factors, right, of complications. So you can't really leave in your calculations. And so then you have to think about, right, what do we have at our disposal as far as tools that we can flag up these patients? Now, you could argue about waist circumference or something like that. It's not done as routinely. And also, we just don't use the other tools for sort of body fat mass measurements as much. So at the moment, the quickest, best way to sort of bring out those patients at risk is using the BMI, but it is flawed. You're absolutely right. So again, as Will said, it's about getting this information out there. So then if you think actually this is wrong and I can see why it's wrong, then please have that discussion with your GP. You know, you're not going to be forced into having the vaccine early. It's just something that we have to run it somehow, and that this is as good as it gets at the moment for us.
Fab.
Cool. Shall I move on to next slide? Yeah. So this is just some clarification. Again, as I said, I'll share these slides out. So who is priority group 6? So 16 to 65, and basically the easiest way to think about this is if you were offered the flu jab, then you're priority group 6. So it's basically the same list pretty much. So people who've got chronic respiratory disease, so that's things like COPD, asthma, there's a bit of clarification needed. So technically, we're being told to target high-risk asthmatics first. So these are people, so this isn't someone who needs the odd inhaler from time to time or just needs inhalers. These are people that are ending up asthmatics who end up in hospital because of their asthma, or end up needing tablets to treat their asthma because they have such serious exacerbations. So those asthmatics will be targeted first before the rest of the asthma population. So if you're asthmatic and wondering why you haven't been contacted and your asthma is very mild, that's probably why. Obviously, anyone with heart disease, people with poor circulation in their feet, so ulcers, amputations, things like that, kidney disease, liver disease, neurological disease, learning disabilities, diabetes. You can see the rest there, and you can see the obesities in there as well. Yeah, and then it's really important to also flag that as part of this priority group are carers. And so these are people in receipt of carers allowance, but also other informal carers. So other people out there that you know there are carers out there who are looking after someone vulnerable, elderly or disabled, or has someone with a severe mental illness, who actually it's in both the carer and the person they're caring for's best interest that the carer gets vaccinated. So please do let them know that they qualify priority group 6 as well. And this is another question that I just wanted to flag up is, so, you know, part of one of the first priority groups, I think 1 or 2, was health and social care, but social care was really sort of vague, and lots of people weren't sure whether they qualified or not. So I'm going to share this slide. There's a lot of information on here, but basically this is the definitions that are being used by JCVI, so the people who set the priority groups. This is what they're setting as social care worker. And I suppose the big message out of here is there was a lot of discussion, I know, in the last couple of weeks about nursery assistants, teaching assistants, early years teachers, because there are other government definitions where they qualify for social care, but according to this, the vaccine prioritization, they don't. So teachers, teaching assistants, nursery care workers do not get included in this, but all of those people in that table do. Okay. Again, I will share that in the slides. Fine. So the next thing I wanted to say was, I thought I'd just spend a brief moment talking about the other sort of big thing that's causing a lot of concern, obviously right now. It is very convoluted, and obviously there's lots of people with lots of different messages out there. So I just wanted to really keep this slide as simple as possible, just so it helps you maybe just form in your own head what are the key messages, and if you needed to tell any other people about it. So the vaccines that we're giving now, currently, so the AstraZeneca and the Pfizer, give excellent protection against the dominant variants that are in the UK. And the dominant variants are basically the original viral strains and the so-called UK strain, the Kent strain. And we know that both our vaccines are really, really good at that, stopping you from getting it, stopping from transmission, stopping you from getting severe disease. We also know, because we've given it 15 million times now, and actually hundreds of millions of times around the world, that the vaccines are really, really safe. So early thoughts about allergies and risk of allergies and side effects and stuff, nothing severe or serious is flagging. So that's really good news as well. We know that the vaccines are going to be less effective against the new, what's been called South African variant, and all to varying degrees. So we know the AstraZeneca one is going to be, so AstraZeneca in a way has got the worst press so far because it's the first one to publish real life data, which is, actually seeing in the real world how effective AstraZeneca is. The Pfizer and Moderna have done lab tests so far, but we've not had as much real world data come out for them. So we haven't got that specific evidence yet for them. But we know we fully expect all the vaccines to be less effective than for the new South African variant. However, we just need to sort of couch that in, we shouldn't get too fixated, because there's a risk with how news sort of creates anxiety and noise around variants, that you'd think that all of a sudden something new is going to sweep over us in the next few weeks or months, and we're all, it's all pointless, the vaccines. But actually, the truth of the matter is that all variants are expected to go down to low levels while we maintain lockdown and social distancing. So they're all going down in numbers over the next few weeks and months. And if we learn from last year, this virus is likely seasonal, so summer numbers will stay low, right? So the worry we have at the moment isn't so much that, oh no, our vaccine doesn't work and the South African variant is suddenly going to take over the UK in the next few weeks, because as long as we maintain our lockdown and then we go into summer with low numbers, that's not a major concern. The other thing to realize is that we will continue to have new variants. This is just a natural process. So we've also got to, I think that's another thing that's happened in the news cycle, is now every time we know there's a variant, it's sort of headline news. Actually, if you look back to last March, there's been tens and tens of new variants that have come out constantly all over the place. And so it is very well expected that we'll get more variants. So that's not in itself shocking or worrying news. And we fully expect that by the end of the year, we're going to be in a place where we'll have variants that the current vaccines aren't effective as much against, and therefore we need a booster. So irrelevant of what vaccine you have now, if we haven't figured out who gets the booster at the end of the year, it might be everyone, it might be people who are at high risk, we don't know that yet. But what vaccine you have now will not, is not unlikely to guide that in autumn, winter. You'll if you need the booster, you'll be offered the booster. So really my message is, although there's a lot of scary stuff going on about variants and stuff at the moment, is make a decision now about your vaccine to protect yourself now, not because of what you think might be useful in winter, because it will be all changed by then, and we'll have boosters around, and we'll be much more in the know about which variants are actually going to dominate once summer finishes and virus levels start to rise again as the weather gets colder. So actually what we're trying to do right now is get vaccinated now, so that we reduce our risk of severe disease and death now, and we also reduce the amount of virus in the community. Because if there's little virus in the community, then there's less mutation going on and less variation emerging, which means by the time we get to autumn, we're in a much more controlled place. So we can say, right, we know there's new variants, but we've got the boosters in place for them. And actually, because we're starting with such low numbers of virus, we can control that. We'll have better test and trace and stuff like that. So I think that's my key message around variants and vaccines is don't let it make you second guess what you're going to have or what you should have. Just everything being given now is safe and effective and absolutely right to take right now. And this will be evolving by the time we get to the end of the year. Make sense? Any questions? No. And the reason I wanted to sort of bring this up with you now is sort of the local Stockwell sort of news, which is even though we've had all this amazing collaboration and this amazing joint effort, what we expected and what kind of was being predicted in national surveys and things is playing out now. So you'd have seen in the news that nationally priority groups for 1 to 4 over 90% coverage. Actually, Southeast London, where your demographics more diverse, and you've got lower socioeconomic scale populations represented as well, it goes down to 80%. And actually, when you get to Stockwell, it's 65% of the priority groups 1 to 4 have been vaccinated. And that's even though, remember, we've offered it to everyone, and that includes sending out letters, telephoning, and texting. And what we're seeing on the ground is basically numbers are low. There's obviously a cohort of patients who just don't want it. They will never have their minds changed, and they've decided that they've never had the flu jab. They don't want this vaccine, and that's fine. But that's actually a really, really small number, and I don't think is something that we massively have to put huge amounts of energy in right now. There is a much bigger cohort of people who are needing time or not sure. And those patients we know often value input from their own GP. So we as GPs have been just physically calling our patients. So last week I spent the whole of Wednesday just calling patients and just talking to them about the vaccine. So it's pretty resource intensive if you think about it, using a GP just to call people for the whole day. But also, if I'm managing to change a few people's minds, that's also really powerful, and hopefully that's a knock-on effect in their families and communities. So there is a definite sort of cohort of patients who would have it, consider having it, but just not now, or just want some more information, which we're concentrating on. And then actually, there's something that we can't ignore, because a lot of people are just out of country. So just to give you an idea, at the Grantham practice, my practice, if I just got rid of deregistered patients that had gone to Portugal or Africa at the end of last year and have been left stuck out there because of changes in lockdown, our numbers will go up to 75%. So there is that caveat when we're looking at numbers in South London and in Stockwell as well. As I said, the national data, which was predicting stuff about lower socioeconomic areas and BAME communities, is starting to pan out. But again, a really, really important message is that it's definitely not about demonizing or ostracizing patients who are hesitant. They're definitely not all one and the same crowd. And actually, there's lots of different reasons that patients aren't getting the vaccine, from either they're not get access to information, language, social media, and a lot of historical mistrust around vaccines and medical interventions as well. just some data that I want to show you. So we can, again, this is very sort of crude. So this isn't something that I suppose is for wider sharing, because it's not, it's not something that we'd want to do a lot more sort of detailed work before this sort of went out to public and stuff like that. But this is running off GP data based on coding. So this is coding, when you register with the GP, if you tick what ethnicity you are. So we have it for most patients, we don't have it for all patients. But if we use that code and then see who's been vaccinated, you can start to see the disparity in the different ethnicities that are vaccinated. And again, this is very much borne out in national data as well. So you might have seen in the last few days national publication about ethnicity in the over 80s group, and sort of benchmark about 50% of Black communities are vaccinated compared to, well, over 80% nationally, but sort of 73-74% locally in Stockwell. So that's where I'm going to end. I would be really opening up. We've got about, well, I was hoping this will finish at 3, but we can go for a bit longer if people are happy to go on for a bit longer. Just to sort of throw out there what we can do differently, or any ideas people have on how we can maybe better engage with communities. Yeah, I don't know if anyone has any thoughts at all.
Yes.
And Councillor Chapter?
Yeah.
Yes, I saw the slide figure, the column.
Yeah.
51 point something BME or Black.
Yeah.
Black.
Yeah.
And others, if I say white population, is around Asian, around 71, 73, 74. Why do you think the numbers varies, and what we could do better? How we can improve that?
That's kind of my question, actually. That's kind of why I'm putting out there. So so I don't want to talk for whole communities. I can only talk for my experiences, firstly personally, because I have parents who are Indians who've come over, and I've heard their stories and why they've been reluctant for the vaccine, but also with patients that I've spoken to directly. And there is definitely there are strong messages being circulated within the community about being aware, being wary of the messaging, trust around what's the truth around these vaccines and how safe they are in certain communities and people of certain backgrounds.
Yes.
I suppose what's striking for me when I see patients that are getting vaccinated. So when I've seen patients who are from the Black community, for example, I've vaccinated people from the Black African community, is how reluctant they have been to share that they're getting vaccinated with others. Yeah, so they're really worried about the stigma. So for example, an example is we have little stickers that we give to people when you vaccinate them. Sticker. And she was like, no, don't give me the sticker. When I walk out of this room, I don't want anyone to know that I'm vaccinated. So this is, I suppose this is why I'm reflecting this back to you guys, because I don't think that, in a way, the more I try and force that issue, the more it becomes the statutory NHS organisations and the community. So really, I feel like the stories and the messages have to come from the community, and I'm wondering how we do that, how I can support you guys to do that. Daniel, you've got your hand up.
Yeah. First of all, it'll be interesting to know what the disparity is between Black Africans and Black Caribbeans, because their vaccine hesitancy is very different for very different reasons. Now I can't, obviously being Black African, I feel like I can't speak for Caribbeans, but it seems to be that on the Caribbean side, it's more so because of institutional sort of mistrust and racism, whereas Black Africans are, there's a bit of that sort of stigma because they're more likely to go to church and they come from more sort of religious backgrounds, and so I think the key thing in terms of driving up participation is convincing churches and church leaders in the local area to be like, this is okay, this is what you need. It's not going to make you a worse Christian or worse Muslim if you if you take this on. But there's just my initial thoughts.
Yeah, no, that's good. Yeah, and I think we so initially the videos that we've been creating have been much more sort of generic announcement videos, so various leaders sort of announcing the vaccine is here or GPs talking about it. But I think now we need to move to much more sort of targeted messaging within certain communities, and it would be great if people in this room or know of or have contacts with people in churches, in faith-based groups in the community that would be willing to sort of front local campaigns, local community media campaigns. Please do put them in touch, because we've got the facilities to do them and create them and stuff. It's just who the right people are. And personally, I've been struggling a little bit to try and find those people at the moment.
Anna, did you want to say something before you have to go? I know Anna needs to leave, but Anna, is there anything you wanted to say before you have to shoot?
Thank you. So it was so I've only supported a couple of people to make sure that they have access to the vaccine, and from the information that was given to us in the previous meeting, I was explaining a little bit, but I've only supported two to three people, and the issue was around language. They didn't understand, and because of that, it generates other issues of mistrust. So can you read this message for me? What does it say? So it was about, but I spoke the language, so that was an easy resolve. So that was easy to resolve from my point of view, because I could speak the language, and so that was it. I'm sorry. I'm so sorry. I had to go. It's my hip issue. I really have to go. See you soon.
But yeah,
Thanks, Anna.
And Anna's point is exactly that. There's different reasons, right? So and so obviously I do a lot of work with the Portuguese speaking community, and for me it feels very different with that community. I think it is much more about language and access, and maybe sort of news from back home from either Brazil or Portugal about the types of vaccines. So as long as I can answer those questions about AstraZeneca or Pfizer and give them information the way they understand, actually I can get them on board a lot more easily or readily, as opposed to some of the other communities. Any other thoughts?
Helen, do you have any thoughts? Or just interested in your perspective. Sorry to put you on the spot.
That's fine. Thanks for that.
Yeah, go on, Helen. On to the vaccine question, please.
Hi, and sorry, let me get my thing. Hi, everyone. So yeah, I need to follow this up with our team, because obviously we've done a webinar with Vic that was really helpful, and we're now starting to sort of disseminate all of that information to our young people. They're quite hard nuts to crack, actually, and I think that there's probably a lot more that we need to do.
Why are they hard nuts? Just so everyone knows that big kids, you do amazing work with young people. A lot of your young people are based in and around the Stockwell area, and I guess are from the ethnicity group that we're talking about, aren't they? I'm just really interested to understand why they're hard nuts to crack. Yeah.
I think because I think it's just to do with the proportion of information sort of for and against. So they consume a disproportionately large information load of kind of conspiracy theories and information, sort of false information, I guess, about the vaccine, that, they're all online looking at all of this stuff and consuming it without much question. And then and I think there's not even this without much question. There's a very imbalanced amount of information online about the vaccine. So I think it's about just doing what we are doing in terms of developing online content, working with them to sort of have workshops where we can talk about all of this and share what we learned with Dr. Vic, and just allowing them to sort of question on their own a lot of the information that they've been given, so that they themselves can come to their own conclusion, but at least be armed with all of the facts and not just with what's going out on social media.
And we can't overstate the role of intergenerational influence as well. So we've had 8-year-old patients who said yes to the vaccine. Lambeth Transport have been organised, picked up the patient, and then as they're leaving the house, it's the children that have come out the house and pulled the patient out of the car and said, "No, you're not going for the vaccine."
Wow.
So that's why, Helen, I was saying to you, even though prioritizing with doing the older groups, I think working now with the younger generations is really key, because there's a lot of going on across dinner tables and in living rooms, which influence the whole family. Yeah,
I totally agree, and I think as well, a lot of our families, often it's the young people that we're working with that are the sort of most proficient English speakers of the household. So they also rely on, I think older people in the family have a lot of respect for the young people and believe what they say, just because they have a better grip of the language than they do. So they're looking to them, to advise, really. So I think they are very key. So we're, like I said, we're kind of working with that. I'm going to bring it up with the team again this week, because we're moving into Dexter's at the moment, and we're doing food delivery. So that's kind of overshadowed everything a bit. But as soon as I can, I think we're going to pick it up. I think they are talking about it though on all the online workshops. So it is sort of slowly but surely getting out there. And I think once we've got sort of a key group who are willing to then create some online content about it, then I think we'll have a bit more of a snowball effect.
Daniel, I'm quite interested, as a young guy from the local area as well as working at the council, what is there anything maybe with Helen? I don't know whether that's a bit of work together, or I don't know. I was just thinking, because the two things that have popped up from what you were saying, what Councillor Jasser was saying, is that you've got some very influential groups of people, the young people, and the churches or faith groups or mosques, or because I know, like, from seeing on the news, like how powerful it was running a vaccine centre at a mosque, and how that transformed it. But we don't have some of that in Stockwell, but how we can get to some of those influential groups. But on the specific one of the young people, Daniel, I don't know if there's something your own particular personal experience might help. I don't know.
Yeah, I mean, my first inclination would be youth council, but there's also thinking Stockwell, a lot of young people still have good connections with Oasis, as in Oasis playground, and I mean, if you're looking at that 14 to 14 plus age bracket, those the kind of young people that the parents that might not speak the language properly, or might not be as attuned with English, will be listening to. So I think there's definitely a conversation to be had there.
I'd like to add Vic. I think we know is the blacks percentage probably 20% lower compared to the Asian white. If that would be the case, those people on the list in general, who they are they yes, Afro-Caribbean, but is African? Is African? There are 55 countries. There are South Africa, Middle East, West Africa, North Africa, East Africa, Central Africa. There are many. So we can do in general as much as possible, but I have more link directly as a councillor, and I'll go around and state, "Hi, I'm your councillor," because there's no meeting, surgery for the councillor. So I just go around knocking doors and introduce myself, and people coming from shopping, people coming when the school open, just try to connect as much as possible to people. Okay, and guess what? I pick up a lot of cases, a lot of issues, repair issue, many issues. So I think there are two. It's important to narrow down the group we need to target. Africa, 55 countries, probably the largest continent on the planet. So who they are, those number, we need to target them. That's one. Secondly, as a councillor, if somebody want to go around and talk about anything, they want to introduce themselves, you want to introduce project to the local people, I go with them, we knock doors. we could do that one too. Say we are from this and this and this, and so far we have done this and this one. We got our center, vaccine center in Vauxhall in South Lambeth Road, and you can give them leaflet, and that will develop awareness. Conversation and face-to-face is always the best solution. And I do that daily basis. I go 3-4 times a week. Hi, I'm your counselor. I'm just myself. Try to be visible as much as possible. That's two locations. So I can go, example, 2-3 times I went to one of the TRA. She want to establish TRA with local residents. I go around and she get the support. She establish. So project going well. That's 2. Third one, we can target it in Stockwell. There is 2 Horn African centers. There is a group of them, Stockwell Road. John, you know them. There's MCA, which is in Wondersworth Road. You got people coming from Lambeth, Sazak, Wondersworth, even far from East London, Western sometime, you know. So that's, we can target the two block, their contacts, their locations, and also we can target church. Okay, so I think that could be one of the things. So we try to do so. From your side, you need to narrow down who they are as much as possible. So that will give us idea and where do you think they're based exactly in Stockwell. Is this W8, W9, W4? Which states? Could be Studley State, could be Marstead State, many as much as possible in general. Then knocking door, that's 2. Thirdly, going to the church, mosque, community center as much as possible. And also going out as I do, we go out to the shopping center, Tesco, Lidl, Sainsbury. Hi, we are this one, this, we could say that as much as possible to be visible.
Yeah, that's great. No, thank you. Yeah, no, I hear that, and we will try and get. We can definitely get more detail. I can do it at practice level. We're not creating that across Lambeth. You know, we're separating out between sort of Black Caribbean, Black African. We haven't got that detail at Lambeth level, but I can definitely look it up in my practice and give a sort of a sampling of it, I suppose. I mean, just again, just through numbers, right? The biggest population, sort of Black populations that we serve in Stockwell, or at least my practice serves, is the Black West African community. So that we're talking sort of Nigeria, Ghana, and then a Black Caribbean community. So those would be the most obvious ones that I'm aware of. So for example, the Eritrean community will be smaller, so the numbers won't be there, right? So there might be lots of hesitancy within the Eritrean community, but I'm not seeing it because the numbers are smaller compared to those other Black communities. But I can definitely look into that. John, did you have your hand up? Has it gone back down?
And Tessa as well, Vic, has a hand up.
Okay, so John and then Tessa. John.
Okay, there are 2 mosques in Lambeth, in Stockwell, of which I'm aware.
Yeah.
And both of those are slightly different denominations or cater to different groups of people. And I think if we can't make representations to those directly and to some of the imams who are preaching there, then we're going to miss a lot of Black people from particularly Muslim people, Black people, and that would be sad. But if we can very easily get a couple of significant members of those communities in those places to advocate the vaccine and encourage people to go in groups from those locations collectively to receive the vaccine, I think we could substantially up our impact across those minority organizations.
Yeah, no, absolutely. And so really my ask is those introductions. So if you know of people, I'm happy to do some of the talking and presenting, or equally back you if you want to do the discussions, I can give you the data. But yeah, it's just how we make those links. Yeah. Tessa, sorry, I'll bring you back in a minute, Councillor Jess. Tessa, you had a
Yeah, thanks. It was just to, I think, take a step back from what's being said and say, as well as the online methods, which are amazing, I think there's also a lot of people who don't connect in that way and aren't using social media, etc. So it's just to sort of think about whether there are other routes in that are non-digital. So obviously several people have mentioned the importance of in-person, though that's obviously a little bit more difficult at the moment given current lockdown rules, but whether there's also other analog options of reaching people, so leaflets, local magazines, local radio, that kind of thing, just to have another sort of channel, another mode of communication which might reach different audiences who are currently not able to, or it's not necessarily easy for them to kind of connect with the online stuff.
No, great point. Yeah, absolutely. And there's also a lot of cable TV, right? So I know that a lot of migrant populations connect with cultures and back home through cable TV and watching sort of channels from back home and things like that. So it would be great if we somehow could work with some of those companies and get some messaging out on there. So, for example, with the LPWP, we do work with Radio Portuguese, and we have a LPWP do a session every Wednesday, and I've been doing some question and answers on that for the Portuguese community. But if there's ways we can engage with local media, media that
there might be other equivalents of that. Had 700, 800 listeners of that Portuguese radio station. So that's a group that you're talking about this. But I wonder if there's other radio stations that in other languages, or I don't know.
So this is also, so I don't, this is almost the call out. If you know those connections, if you know who those people are, please do introduce and bring them to this group, and I'm happy to sort of do the discussions with them and stuff.
What I will do, I will I'll speak to them first, because they are on, because I should have discussion and meeting with them soon. Next week. There is a lady imam in Wandsworth, Mosque, imam in Stockwell Green, and also there is a lady, she's also center manager, and also she's a treasury of finance. So I'll speak to them and both to mosque, and also, so we may there is even possibility. I'm planning to do event for community group here in March. It's going to work out. We'll see. It's going to work out online. We may give you 10 minutes, 8 minutes. You come talk about the topic and go away. You know. So we'll try. And Horn Africa and Arabic speaker, most of them speak in Arabic in East Africa, Horn Africa, and North Africa. So we made a session in Arabic, session Portuguese, session Spanish, session Polish. And that helped. And also Daniel is from West Africa. So there is, I will find out from Lambis population Afro-Caribbean in Stockwell, around the Stockwell area. So there could be many people speak Swahili, which is a bit of Somalia, but mainly Kenya, Uganda. And I need to know their populations. We got Amharic, we got Tigrinya, we got Somali, which is the Horn Africa. Horn Africa, 4 countries. Ethiopia, Somalia, Eritrea, Djibouti. Djibouti, they're not here, small nation, but mainly they speak French. They're based in France and Belgium and Quebec and Canada. But those, the Eritrean, Ethiopian, Somali, they're central Lambus in Stockwell, and Brixton also some extent. Streatham, Somali, but the 3 groups together in Stockwell, and they got community center in Stockwell Road. They've been for over 25, 30 years. John, we know them. I do have connection with Stockwell Partnership. So I was work volunteer in management. Probably I know John 18 years ago. Used to be former, what's the name? I mean, due to financial difficulty and a lot of reasons, Stockwell do not play great role, but used to be a big organization, helpful for many organizations. They got great record, and so that's why we could do session in different language. We can do target directly to Somali, Somali language, to the Tigrinya, which is Eritrea and Ethiopia, Amharic, which is main language in Ethiopia, additional Arabic. So that will cover Horn Africa, North Africa, Middle East. Wide good range. We could do Portuguese, Spanish, Italian, then African language, which is like Swahili, could be Yoruba, but I need to find out the population Lambis Horn African. I mean African, whole Africa. So it could be 3, 4 different language, could be Yoruba, could be Hausa, could be many. So I'll find that information.
Wow. That's amazing.
Okay,
Just do all of the sessions in all the languages.
Yes.
I love it.
This session. So,
I mean,
sorry, go Helen.
I was just going to say, I think doing this kind of, it'd be great to sort of get the word out via Lambeth, and then sort of I'm just kind of thinking of all the church leaders and, you know, what kind of, I don't know, I'm not a church leader myself, so I don't know what kind of email, you know, round robins they're on. But I think, I mean, certainly in terms of, I know less about mosques, but I know in terms of like Christian churches, there's quite a lot of sort of quite large Black churches in that sort of Brixton and Stockwell that presumably be fairly easy to target because there's not that many of them, but there's a large concentration of Black people going there. So but I don't know whether they'd be necessarily, I don't know if religious leaders are necessarily on Lambeth's you know, are they subscribing to Lambeth's newsletter? So would they get it? So I don't think so.
Yeah.
I think it might be just a sort of, you know, in-house approach somehow. But then if it's a targeted kind of webinar, seminar for religious leaders, I think that would be something that they would want to attend, especially if there's an offering in, you know, if there's a translation offering, although that's a little bit harder to, I don't know, do all in, you can't do all the languages in one seminar, but there's a way of doing it. This is not my area of expertise, as you can tell, but I wanted to offer something more in our area of expertise, is that when it comes to sort of youth stuff, obviously we'd like to create kind of an online video that we would have our young people doing, and happy to work with other young people on that as well. Once that's done, obviously I'd love to I'll distribute it to you guys and we can distribute it out. But beyond that, if there's young people from, say, the council, or there's young people from some mosques, or there's young people from some churches who want to do their own video, that's something that we would be happy to facilitate and work with them to you know, come up with the idea, film it, edit it, all of that.
Lastly, Big Kid Foundation, Oasis, you can join together, and Vicky can do a presentation 40 minutes, 50 minutes. So just show for young people.
Yeah, 3 minutes, 3 minutes. 40 minutes. Young people have got 3 minutes max.
Yeah,
exactly.
No, that's all great stuff. Thank you. So yeah, I think what's really key, and what I'll do is I'll follow up with you individually, is just those introductions. What I would say about the churches is, I know that South East London commissioners have done some communications exercises with leaders, basically. So they did one for religious-based groups as well. So it's happening at a very high level, but my is there needs to be some sort of local conversation where it's literally me, local pastor, some local influential people having a conversation saying, right, how do we do this for Stockwell? So I do know that, for example, the churches of South London have come together and created their own videos and sent them out on mailing lists and stuff like that. But it all feels quite high level at the moment. I think there's something quite specific that just needs to happen locally that makes sort of a tangible, sort of a relevant message, I suppose, for the local population. Cool. Okay, we've gone way over time, so thank you everyone for sticking around. Is there anyone else who wanted to have any last minute thoughts or comments before I?
There's this question of it. You know, we had the vicar of Stockwell. Erica, yeah, because she might well know the other religious leaders in the area. I'm sure she does, so she might be someone to contact that. And then the other thought I had was, Helen, you were mentioning, you know, once you've got that video, those young people, presumably some of them will be part of churches that you were talking about. You know, how can we use that video almost maybe as a, can you play that video in the church or send that round? I don't know how the churches all communicate, whether they have newsletters, but the young people have quite a, you know, they have quite a lot of influence, as you said, in the households, but whether they have that influence in, you know, all the connections into the church, I don't know. But
I think that'll differ from church to church.
Yeah.
But definitely, yeah, I know some of our young people, a lot of our young people are at various different churches. So already there's a number that we could reach through that way.
The key to this is going to be those connections, the individual introduction to someone. Does someone know someone that they can facilitate the call? And then probably having Vic involved as the local GP that's doing it. It's that helping Vic get that conversation, and then we're almost off and running. So yeah, whatever we can all do to find those connections, I think.
Yeah, exactly. And the last thing just to throw in there is we do have an option if we think it's, you know, you've seen on the news these good news stories of doing vaccines in local mosques and churches and community sites. We could try and push for something like that and set something like that up in Stockwell. My only slight reluctance is which venue. Like, we've got such a diverse population in Stockwell that no matter which venue you choose,
yeah,
it feels almost a bit too sort of narrow for the diversity of what we have in Stockwell. But no, that is also an option. So if we as a community thought that actually there is a certain venue we could run vaccines from that will actually be a lot more accessible and get more people involved from different communities coming to, then that is something I'm happy to take back up to Lambeth.
You know how you do home visits, Vic? Can you just go like, on this day I'm going to go and do 10 vaccines at Esker, for example, and I'm going to do 10 vaccines at someone at the church, or can you do it like that, or do you have to have because I know you can do home visits, but
you can technically, you could, but it just need a bit of planning because of patient data. So obviously we need to record who we're jabbing. So obviously when we invite our own patients, we have all that data there. So if you're just opening the doors to anyone from the community, I need to be able to somehow capture that data. Data things, and also when I vaccinate someone who's my own patient, I know their medical history, so I can screen. Whereas if it's someone off the street who's just come into a community, I don't know their medical background and things like that. So, but yeah.
Last thing I could say to you, there is Stockwell Vaccine Center, which is Whitfield Hall, Community Hall. Probably you could do a video 5-10 minutes. This is the way center is. This is I so talk about it and just facilitating videos, talk to the staff, probably 10-15 minutes. That will help people just grab attention. Yeah, he's here, and it's great. Let's go out. Even if he's not going to do it, he may go to explore and ask. So that could be one of the 10, 12, 15 minute video. You could do that 10 minutes, whatever it is.
3 minutes.
Yeah, well, yeah. I could link you with the Lambeth Face group, but this is project only focusing now in Stockwell. So it's not going to make it across Lambeth, and after the message only local for the Stockwell. For that reason, it's better to target local church, local mosque, local temple, local community center. And the other thing is, if you want to go out to speak to knocking, and be visible in the States, outside food store, outside Sainsbury, outside, I don't know, Stockwell station, I don't mind. I'll be available with you.
Yeah, no, brilliant.
Okay.
Brilliant, that's suggested. Okay, I am going to end it there. We're going to be talking all afternoon. But no, thank you so much, guys, for coming today. And I will be chasing. So the next steps, really, I think, are just sort of individual conversations that I need to have with some people here about who we contact and how we make those bridges. So I'll follow this up with a few of you here and try and make those connections. Okay.
Thank you. Good to see you all.
Thank you.
Bye.
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 Bye.